So goes on. It's a Happy New Year to you. Please read this and come back to us. And by the end of, middle of January, we get this back with comments, additions, amendments, or whatever. We have a list of what we call must-dos. The first of all was mentioned this morning about quality accounts. The quality accounts apply to England. I suspect that something similar is going to apply here in due course, but in the quality accounts there's actually a list of national audits that are valid audits and collecting data in the year. So we expect participation. When I say valid audits, they're proper audits, they're robust topics, they're properly sourced, they're properly managed, and all sorts of things. I mean, I could set up an audit, I could send an email around I've said this before many times, to chief execs in England, saying, look, we're going to do this audit on spots on bellies, can you sign up for it? And I get 20 trusts signed up for it. Don't know why, it's just, people just sign up for things without knowing about it, but that's the way it is. And I've seen this sort of thing happen. We actually then put on, after the national musters, we've got the regional and the local ones that we also want to put on there. And this is where our colleagues internally can provide the information. So it's anything to sequence this one, because there are some regional Commissioning for Quality and Innovation initiatives, as well as national at the moment. We may have some specific changes we're going to do with the commissioning, and they want to build things into there. One example of that is to do with DNA CPR, where we've changed some of the issues around the ways in which that works. We wanted to build, make sure that all our providers audited that properly. As far as England is concerned, we have systems called DESIs and LESIs. You have them here, do you? Do you have them here? You do. Sorry. Directly enhanced services and local enhanced service. Basically, if a GP provides an enhanced service on a particular topic, they get paid more. However, they have to demonstrate they're doing it well in order to get paid more. So they have to audit things in order to get that put through. So any GP that signs up for DESIs or LESIs, and it could be on one of several topics, they have to do audits, so we build those in as well. And any other key local priorities. One of the ones for 1011, for instance, was on dental recall. Nice guidance on dental recall. I was about 5 years old, is it, Chris? Like that?
I think so, yeah.
Yeah. States that you don't have to go back to your dentist every 6 months. It varies. Dentists should vary it according to the condition of your teeth, effectively. And so our dental public health people were concerned that this wasn't being followed very well in Sheffield, and they wanted this specifically to be checked through. So that was built in as a local priority. Same thing could apply anywhere. Incidentally, we found that 50% of our dentists don't follow NICE guidance on this, and they're going to have their little bottoms kicked. Because, of course, if they do it properly, it means that they can actually see more patients, if you think about it, through the NHS, because they're not wasting their time on seeing people every 6 months inappropriately. So anyway, we send out our commissioner draft to providers in January. And we have meetings as held necessary to resolve any issues, phone calls, emails, whatever. And basically, they come back to us by middle-end of February, having checked when we tweak the programme as necessary once again. Occasionally, for instance, we find out that we know something, there's a national audit going on, we think it applies to our acute trust, and we find they don't provide that service anyway, and so they don't need to take part in it. These are things that does happen. But anyway, essentially, by the end of March, it's signed off by the commissioner body and by the governance committee or whoever in the provider organisations. So by the end of March, everybody is signed up to it for the year ahead. Okay? So we all know where we're going with it. We all know what the priorities are. And hey, all of a sudden things are going quite well. So as an example, this is actually from 2011-12. It's very simplified. So the organisations across the top are NHS Sheffield, that's us, if you like, and our people that are employed by us. SPCT is the Sheffield Primary Care Trust Community Services. Sheffield Teaching Hospitals. Sheffield Children's Hospital is a separate trust, so Sheffield Teaching Hospitals is adult only. Sheffield Children's Hospital is acute children's trust. And finally, Sheffield Health and Social Care Trust. Okay? That's health and social care, so it's one of the few care trusts that we have in England, but they do exist. And this is a list, just a list that I picked up, not random, it's just a list that came together to illustrate this. So all trusts have to do a record-keeping audit. Suicide audit applies to those organisations. Patient outcome and death, which is one of the confidential inquiries, corpses. Maternal newborn, child health, asthma deaths, lithium therapy monitoring, vaccine cold storage. These are our priorities. These are driven from on high and from below. Now you can see that most of them apply to more than one organisation. So we can now identify perhaps where one organisation should lead on behalf of the city and work collaboratively with all the others. But we don't want them all doing the same, developing an audit tool, which eventually is the same one, doing the same data setting up a data process for data collection, which is the same one, etc., etc. Just do one, share it. So we actually can save resources by doing this within audit teams, freeing them up to do all the local audits which are not on this commission list. Yeah? That just gives you a flavour. The total is, because there's quite a lot in the quality accounts, there's about 53 national audits in quality accounts in total. Don't mean to say there's 53 apply to any one organisation, because it doesn't. Because there are 7 that are prescribing for mental health for a start, and should only apply to mental health trusts, and so on. So, but the whole list for the City of Sheffield is probably a region of about 70, 75 topics, which are then spread out across the city. So basically, the effect of this programme is, it's a contractual requirement. You will follow it. It gives direction to providers. It actually gives leverage to provider departments in audit departments in provider organisations, because they can say, no, we can't do your audit, Mr. Junior Doctor, on fractured neck of femur, like the one we did last year and the year before and the year before, because that's the easy one to do. We're going to do the ones that are important to the organisation. You recognise that, didn't you? Yeah, fractured neck of femur is a great one for. I've got to do an audit. I thought I'd do fractured neck of femur. Oh, yes. Well, can you help me, please? Yes. Well, I've got to do it by Tuesday. Yes. Anyone else recognise that one? Or is it just me? I've been there, done that, tell you. So we don't do them. We do focus on the priorities for the organisation. So it focuses resource usage as well. It provides consistency across the health community, so all people are working together. There's no point in that direction anymore. And believe it or not, providers like it. It gives them a meaning. It means that they're embedded into the organisation, the whole ethos of the organisation. So, it's in place. So we need to monitor how it's going. Now, some of you last year might be familiar with this, but I'm going to look at the clinical audit programme, and I'm just going to park nice for a minute. This isn't nice. This clinical effectiveness, as far as we're concerned, in Sheffield is nice guidance. We take it very, very seriously. But I must point out, it's not always necessary or appropriate to do an audit to show compliance with NICE guidance. If NICE guidance, and there's been several of them come out and says, do not prescribe this drug, how can you audit that you didn't prescribe it? Well, you don't, do you? You just look at prescribing data. Why go through the whole process of setting up an audit to look at something which you can get elsewhere? So that's the first thing. Sometimes an audit is insufficient to show compliance anyway. I can remember a nice clinical guideline of 33 on epilepsy, something like that. In the 30s, it's an older one. That had 203 recommendations. Now, how do you do an audit for 203 recommendations? Basically, you don't. You take a reasonable view, look at the various parts of it, say, look, these are the key bits. but they're not, they are discrete. So we'll do separate audits. And in fact, in order to demonstrate compliance, the trust in question, Sheffield Teaching Hospitals, actually did 7 audits. And there are many other sources of information that can be used to show compliance. At the end of the day, we want our providers to comply with NICE guidance. That's what the quality contract says. You comply. It doesn't say you audit. And compliance can come from a number of sources, of which these are some. It's not an exhaustive list. It's not a one-size-fits-all. It depends on the guidance. You may need to do an audit for this particular item of guidance. You may not. It's up to the provider to demonstrate they comply. That's the important thing. It's not up to us to do it as commissioners. And there are all sorts of things. I mean, you might want to include the fact that training has been given to staff members on how to do a particular aspect of care, because that's what the NICE guidance indicated needed to be done. You can't audit whether that's happened. There's prescribing data. You might have had various events. You've got patient feedback. You've got PROMs and PREMs. You've got policies, pathways, protocols. They may well have been updated and validated on the back of the NICE guidance, and I would sincerely expect that to happen on a regular basis. But you don't have to audit, which is why we take a different approach to NICE guidelines. And all NICE guidelines apply to everybody unless they can prove otherwise. It's a simple rule we take. So even though it says this is a guideline for caesarean section, we still say to our children's hospital, do you comply with this guidance? And then they will say it's not applicable to us. Okay? So it's up to the provider to take that decision. And then we will have a look at their decision and try and validate it. So that's the difference between audit and effectiveness or audit and NICE. Incidentally, we have checked this with our colleagues at NICE, and they acknowledge that this is an acceptable way of doing it. It does mean that you free up audit resources to do things which are worthwhile again, and not just doing it as an audit to tick a box to say I've audited whether we comply. So there are all sorts of advantages of this on the way. As far as monitoring of this is concerned, we say we want a quarterly update report from all providers. It's a simple sort of spreadsheet approach. Each quarter, it's colour-coded boxes to say whether it's blue, green, amber or red, or we call it our BRAG rating. It should be BRAG, but we can't really call it that for obvious reasons. Blue says we're complete. This is done. But we also require a list of the evidence that you have to support that statement. Green says we're progressing well, okay, but we also require a list of evidence to support that statement. It's a simple list. But of course, when you've got a nice clinical guideline, say, which you've got 3 years to implement, it's going to be green for quite a long time. But we know that, we're reasonable about it. It's not something that happens overnight. Yesterday we didn't comply and today it's come out and we do comply. It doesn't work like that. Amber and red are obvious colours we're used to. But with them, we look at things and we do detailed evidence for specific projects. We'll come back to that in a minute. We do a quarterly board report. We have quarterly contract meetings with our providers. These are official contract meetings. And the information from performance in this clinical audit and the clinical effectiveness programme for the year is actually fed into all this. And we, in Sheffield, have a general monthly meeting, which we have, clinical effectiveness meeting, with all providers together so they can share issues about progress or lack of it and so identify ways forward or improved practices internally. Bit of an example. My favourite subject. We've got a national clinical audit and patient outcome programme. This is a national audit, and this acronym is quite well known in England. It's the old NCAPOP. You have an NCAPOP audit of toenail clippings. It's come out, we've got to get on with it. Quarter one, it's red. We're stuck. We can't identify an audit lead. It ain't going to move until we do so. So keep an eye on this one.